before getting started and introducing our presenters, I did just want to talk a little bit about language. Inclusive language is something that we all here on this presentation are staunch advocates for. We understand that words matter and that language should be used to empower, to uplift, and to support. We also understand that language is a living thing and language can change very frequently. Myself and David and Allison and all of our respective organizations do our best to listen and to be respectful of those in the autism community, learning from them and prioritizing their perspectives and preferences. And we ask the same of everybody who is participating and going to be participating in the chat as well. We also recognize that there is always room for growth and learning and improvement, and we welcome feedback from anybody who is attending this presentation around our language choices. With that said, my name is Amanda Falk. I am a partner and chief clinical officer at The Dorm, which is an intensive treatment community for young adults ages 18 to 30. We have locations in both New York City and Washington, D.C. We work with many clients on the autism spectrum and with clients who are diagnosed with other forms of neurodivergence. This is why we are so grateful to be joined today by both Dr. David Rowe and Allison Kleinman to help us learn about the method and value of neuropsychological testing, specifically for this age group that we work with. Dr. David Rowe is the founder and director of neuropsychology at United Assessment, which is a group practice specializing in high-quality psychological assessments, including psychoeducational testing, psychodiagnostic testing, and neuropsychological testing for adults, adolescents, and children in New York, New Jersey, Connecticut, Washington, D.C., Florida, California, Arizona, and Montana. Allison Kleinman is the founder of Future Centered Care, which is a group that partners with neurodiverse adults and their families to curate meaningful, supportive, and secure systems of care for now and into the future. Allison has been working since 2009 as an advocate for people within this community and their families. She is focused on and dedicated to improving employment, housing, and future planning options for this community. She is also the founding director of the Jack and Shirley Silver Center for Special Needs at the Marlene Meyerson JCC in Manhattan. So without further ado, I am going to now turn this presentation over to Dr. David Rowe, who is gonna get us started.
Perfect. Thank you, Amanda. It is always a pleasure to be here with you. Let me just adjust my screen real quick. So to start with a little bit of an agenda, we're going to start by talking about the importance of evaluation. Anyone who knows me knows that as a neuropsychologist, I see myself first and foremost as a statistician, and I can't help but wax poetic about the power of data. And then we're going to review the makeup of a mental testing battery. And finally, I'm going to speak to the value of valid, reliable psychodiagnostic testing for young adults. And then I'm going to hand it off to Allison, who's going to discuss the integration and intervention. And obviously, we'll conclude with plenty of time for questions and answers. So first things first, disclosures. The following slides are for educational purposes only. Absolutely no solicitation is being made to any attendance or viewers, and the opinions I express are in fact mine and don't reflect those of United Assessment. So let's talk about testing. Let's talk about assessment, and at its most granular, let's talk about data. Many of us came from a generation with very little acceptance of mental illness and virtually no psychoeducation. And now we live in and we work with a generation with nearly infinite acceptance of behavioral health issues and developmental differences, and still with very little good psychoeducation. And the emphasis is on the word good because it's not for lack of information. There's literally data everywhere. The problem lies in both miscommunication and misinterpretation, which is to say the way the data is presented and how we understand it. So let's start with data dissemination. We can all agree that misinformation is everywhere. A shocking number of our clients are getting the majority of their medical advice from apps like Instagram and TikTok, platforms that perpetuate falsehoods like ADHD is part of the autism spectrum, or that Tourette's is somehow contagious. There are clients who strongly identify with their IQ scores that they derived from a BuzzFeed quiz. And to be honest, I can't blame them. Who could? It's human nature to try to understand oneself. But speaking of human nature, it brings us to our issues with interpretation. As humans, it's extremely difficult to discern good data from bad data. For the most part, humans are not intrinsically good at statistics, which is a real problem when there are few truer proverbs than garbage in, garbage out. We're prone to emotionality, which often causes cognitive distortions, right? We do things like hope, which is why we play the lottery, or we deny, which is why we drive on the highway. And we don't think about the numbers, and it's really, really difficult to know what to believe. And because of this, in terms of our field, we have voluminous evidence of self-diagnosis, of misdiagnosis, of over-identification, of under-identification with disorders, of confusion between things like incident rates and identification rates. And like I mentioned, it's made much more complicated by the biases that we all intrinsically carry. There's the strategic misrepresentation, there's the optimism bias, there's the uniqueness bias, the planning fallacy, the overconfidence bias, the hindsight bias, the availability heuristic, the base rate fallacy, the confirmation bias, the fundamental attribution error, and that's just to name a few of the innumerable systematic patterns of deviation from rational judgment, right? So now we have a big problem. We are at a double disadvantage. The information we source is skewed, and our ability to interpret that information is flawed. And that is where assessment comes in, to try to provide clear, focused, unbiased data. In a world of inferential and impressionistic diagnostics, assessment removes as much subjectivity from the process as possible. Is this covering this? Let's see that. All right, I didn't realize that the whole time. So, in honor of National Autism Acceptance Month, we're going to focus on developmental assessment, testing for developmental disorders, specifically autism spectrum disorder. And again, we need to move away from subjective judgments, like what autism looks like or what looks autistic. We need to not make assumptions, not the client, not the family, not the treatment team, not the public. By the very virtue of autism being a spectrum, the neurodivergent community is not a monolith. It's not homogeneous. We need to do our best to understand the individual. And that's why identification and understanding of specific foundational developmental differences can be instrumental to the treatment process. Principally, the criteria for ASD are bifurcated into two very distinctive, very disparate domains: persistent deficits in social communication and social interaction, and restriction and repetitive behaviors of interests and activities, which we call RRB. On the social side of things, this can manifest in issues with social emotional reciprocity, with understanding nonverbal communicative behaviors, or developing, maintaining, and understanding relationships. On the RRB end, it can include stereotyped repetitive motor movements, cognitive flexibility or ritualized patterns, fixated interest, or hyporeactivity to sensory input. However, the criterion I want to draw the most attention to today, because I feel it's the most applicable to young adults, is criteria C in the DSM. Symptoms must be present in early developmental period, but may not become fully manifest until social demands exceed limited capacities, or may be masked by learned strategies in later life. Demands exceeding capacities. It's not uncommon for a young adult to be recommended or even asked for developmental testing, especially to make sense of why they might feel different. It's in this developmental period, due to the stark increase in the complexity and the intensity of relationships and life demands, that we are able to see demands exceed capacities. Often it's in clients who either required a lower level of support growing up or already benefited from a high level of support, which is all to say that many young adults are presenting for testing who might meet the criteria for level 1 autism, who haven't been previously identified because despite signs and symptoms, there wasn't enough evidence of clinically significant impairment in functioning. But of course, the current emerging adult population also lived through the COVID-19 pandemic. And when school converted to a virtual format, they lost their opportunities for structured social engagement and they struggled to create their own. And the unfortunate nature of this unparalleled stressor is that it quickly created circumstances where demands exceeded capacities. So now we've talked about what ASD is and why we provide developmental testing for young adults. Let's talk about what that testing looks like. We use standardized tests, observations, interviews, record reviews, and inventories to gather the most holistic picture of a client developmental profile as possible, with the goal of identifying differences, deficits, and deviations indicative of a developmental disorder. And so the three key domains in developmental assessment are cognitive testing, social emotional testing, and testing for adaptive functioning. Again, because individuals with ASD have unique abilities and challenges, it's essential to use standardized measures of intellectual functioning, speech and language, social relatedness, and adaptive behaviors, as well as other aspects of mental health. We start with a gold standard test of cognition, such as the Wechsler Adult Intelligence Scale, the WAIS, which provides information about both general ability, verbal comprehension and perceptual reasoning, and cognitive proficiency, which is working memory and processing speed. And this is essential to determine if any of the client's presentation is better explained by or is accompanied by intellectual or language impairment. Then we move on to social emotional tests. For example, the Autism Diagnostic Observation Schedule, currently in its second edition, which is a semi-structured protocol consisting of a series of activities and tasks that elicit social communication and repetitive behaviors typically associated with ASD. The ADOS-2 provides a systematic framework for observing and documenting behaviors across contexts, which allows trained clinicians to assess the presence and severity of ASD symptoms objectively. And it's important to note that it includes modules tailored to different age ranges and language levels from toddlers to adults. And then finally, we want to do adaptive functioning testing. Using a measure like the Vineland Adaptive Behavior Scales, the Vineland-3, we can detail a client's ability to perform daily living skills necessary for independent functioning. We parse apart communication, activities of daily living, socialization, and motor skills so we can better understand a client's various support needs. So while these domains might provide a high level of statistical confidence to make a valid ASD diagnosis, due to the high rate of comorbidities, further psychodiagnostic testing should also be strongly considered. So ASD is often mistaken or diagnosed alongside other developmental diagnoses. It's important to delineate ASD from attention deficit hyperactivity disorder, communication disorders, intellectual disorders, motor disorders, or specific learning disorders, any other disorder in the developmental domain. In our work, we also see ASD diagnosed with other non-developmental but psychiatric disorders. Because of the constellation of symptomatology, growing up with either diagnosed or undiagnosed ASD can be very difficult, especially during vulnerable developmental periods. For example, struggling with social emotional reciprocity, despite having high social motivation, can result in difficulty actualizing close connection in intimate relationships, which in turn can trigger and perpetuate depression and anxiety. We've seen foundational developmental differences result in relational traumas that manifest in everything from mood disorders to personality disorders, which is why it's important not just to understand the particulars of neurodivergence, but the full scope of one's experience. So, while all individuals are far more than any given diagnosis, the potential value of a proper diagnosis can't be overstated. It can provide clarity and validation. It can help families and individuals and treatment teams understand the underlying reason for challenges. With a proper diagnosis, individuals can access appropriate interventions, support, services, accommodations, all tailored to their specific needs. It often leads to improved outcomes and enhances the overall quality of life. So for young adults specifically, a proper diagnosis can be critical as they navigate that transition into adulthood. It can empower them to understand themselves better, to advocate for their own needs, to have a name for their experience, to access the supports and resources necessary for success, both institutionally in terms of education and employment, and also personally in terms of relationships and independent living. The results of high-quality assessment can be used instrumentally to foster self-acceptance and belonging within the neurodivergent community, a community that might better understand and respect them, which reduces stigma and promotes inclusion. So testing is finished and a client has been properly identified as on the autism spectrum, but not just that, we have a trove of individualized clinical data that demonstrates their particular strengths and challenges. What do we do next? How does assessment impact intervention? And now I'm very lucky and happy to be able to pass this along to Allison to explore that question further.
Awesome. Great job. Thank you. I'm going to share my screen. Okay. Everyone can see that? Okay, cool. Thank you, Dr. Rowe. That was a perfect transition. And a lot of the work, I'm Allison Kleinman, by the way, a lot of the work that I do and how I got to this place is really around helping people make sense of why they feel different, like you said. So that really struck a chord with me. I worked with adults with developmental disabilities for 14 years in a community center. So my approach was always around finding their individual path while also making sure they have a sense of community and belonging. And really, we're talking about a sense of self-esteem and validation, like Dr. Rowe said. 2 years ago, I started a company in much part because of the parents and the advocates themselves and the struggles I saw in them leaving the school system. In New York, that's 21, some states it's 22, but once you turn 21, they call it falling off the cliff. Sure, people have heard of this. So you lose education, programming, services, funding, everything you got through the IDEA goes away. And so what we saw were adults who were in their teens and becoming young adults, and they basically were left to start over. And that fell often on the parents. So once, parents are looking to let their child move on, be free, become independent, the opposite was happening. And the emotional and practical burden and responsibility was put back on the parents. And, the way I always look at this is like, it's not really appropriate for parents to job develop for young adults. So who's going to do that? So we started this company, Future Center Care, and really the focus is on helping people with that cliff after they transition out of school, really looking at people in their 20s all the way up to 40 in terms of building and rebuilding a life. And then, which I'm not going to touch upon a lot today, but the idea of future care, what happens when parents are no longer here? And those are still some of the really big issues we're working on, as well as housing, which is a big one I focus on. So I'm just going to go forward really briefly, but it wasn't very long ago that we had institutions. People with intellectual and developmental disabilities were put into institutions. Thankfully, that went away in the 60s or 70s. They started to create new certified group homes. Families thought, great, this is going to be a new opportunity, and my young adult can stay here forever. There were a lot of problems and are a lot of problems with group homes. And so now, 20 years ago, so someone who was born 20 years ago is growing up in a time where there's a lot of advocacy for new solutions, a lot of focus on choice and individualized options. And so today we're creating a more open and adaptable and sustainable system of support to help families have the ability to choose services and adults to live where they want to live, with whom they want to live, and find their own staff. They can choose their own staff at this point. So it's a whole new world out there with a ton of advocacy still needed at the state and federal level, which is happening state by state. So also, just to go through terms again, we're talking about autism, but we're also talking about neurodiversity, which is really the idea that differences in how the brain develops aren't problems that need to be fixed or cured. They're just variations. And so the work that we do is really about helping adults contribute in the ways in which they can contribute. So we're looking at, Dr. Rowe covered a lot of the comorbidity and co-occurrence that happens here. An estimated 56% of autistic adults experience some type of psychiatric condition. And then just to bring it down and transition into what do we do with these evaluations? Executive functioning is a huge term. It's something we all think about, and it's basically the umbrella term for a cluster of behavioral symptoms: self-regulation, planning, shifting, focusing, and this directly relates to who is the adult and what are the accommodations they need. So this is just a sense of the different ways in which we look at building someone's life and the people and the different components that make up their life. And now I'm going to get into why are these evaluations important. So when we, as case managers, look at a neuropsych or psychological, it's very helpful actually to have that relevant background information. So we work with someone that's 21 or over, and basically, we do our own sense of an assessment and go back with family history, but it's very helpful to see a snapshot of what's happened over the last 2 decades, what's happened over the last 3 decades. we look at who's the treatment team already here, who's the psychiatrist, who's doing the evaluations, and we partner with them to figure out what's the type of recommendations they have in terms of therapy or in terms of other mental health interventions. The behavioral observation is very important. That's, our version of you're going into an interview. What's a supervisor or potential employer going to think of you? And when, someone, that does these neuropsychs can say very clearly, hygiene, or these were the things that stood out to us. It's very helpful to see those, to be able to make sure that, those are the things we're working on. We're looking at the cognitive functioning and learning challenges. And then a big one that I'm not going to go so into because every state's a little bit different, but there's some significant funding implications that are connected to evaluations. And when we look at an adult and understand who they are, what their strengths are, where the deficits are, we're also thinking about what are their resources, right? Because if we're building a life for them, we need to understand if they need to be self-sufficient, independent financially, or is this someone who can and is eligible for taking advantage of certain entitlements, Social Security or DD funding, and also parent resources as well. So we like to look at ourselves as matchmakers. The work that we do is we take a neuropsych, we learn about a family and the adult, and then we match them with the right social opportunities, the right volunteer opportunities, big unemployment, that's supposed to say friends and romantic partners. Also really focused on housing and staffing and health and wellness. So we look at these different areas and we get to know the adult in kind of a discovery phase. And really we see it as understanding the local partners, making connections, nurturing those connections to understand what's going to work and what's going to be sustainable. So I want to look a little bit as a specific example around job development. Most people in their 20s, who have been to the dorm or have other types of treatment programs, ultimately, what are they doing during the day? Or what's making them feel good? How are they contributing? So we take a customized employment approach often, where we really look at the strengths and needs and interests of the individual. What are they motivated to do? And then, like most people had either an IEP or a 504, the need for accommodations doesn't go away because you're an adult. It just, the language might change, or transferring what the child needed in a school setting into what they might need in a work setting looks different, but really it's all kind of those same underlying challenges in terms of their executive functioning or their social skills. So we do a very thorough discovery process where we're really, because we're not therapists in a sense, we're out in the world with our clients. And it really gives us the opportunity to learn different things that a lot of people may not know about the individual. So, if we're taking a walk with someone in the park and they're stopping every 2 minutes to pet dogs, okay, we know that maybe has anyone ever thought about them working with a dog, right? We're not geniuses, but we are creative and we're just constantly observing, So what is it that we don't know? What is it that the neuropsych didn't share about the adult? That's the stuff we're looking for in the discovery process. Then we put together a vocational profile. So this really covers what are the tasks, the schedule, the way someone understands information, what's the right environment, who's the right type of supervisor, how does the individual take feedback, what are the problem-solving skills, how do they ask for help, can they ask for help? There's a ton of accommodations that can be utilized here as well. There's a lot of technology, more and more, that really can make this much easier for adults and for their supervisors and employees. And then we look at this customized approach where we're really reaching out to employers. And now, because of, neurodiversity has its own month, the stigma is changing. Employers are more open to understanding and customizing different opportunities for adults. So one thing I've been doing for a real long time was task reassignment, where you go into an employer. And I mean, I would just say that, often the best way in is someone who's related or connected to someone who has a disability, they're going to try to champion that effort, whether they're in the HR department or not. So finding kind of your way in, that often helps. And then really saying, let's look at the tasks that this adult can do well, and how do we take some of those pieces out of someone else's current employment so that they can be freed up to focus on their central core work, and that we can create work that somebody that we're working with can do potentially in a repetitive, routine way and enjoys doing. And we look at, like Dr. Rowe was talking about, demands and capacity. We look at speed and accuracy and efficiency, and how do these things affect each other in the workplace to understand what's the right level of demand to get the optimal performance. There's job carving, which is, it's very rare that for someone who has a developmental disability, we look online and say, okay, apply for this job. We can see jobs and we can say, okay, John can do A through M, but N and below can't do that. So we speak to the employer and say, can we carve this out? Same as job sharing, which is, splitting a job into 2 different roles, which we've done a lot. And a lot more, we have a lot of adults who are creating their own businesses. We have someone who's in film, we have someone who creates bracelets, and there's incredible social enterprises popping up, which I love. The only challenge there is once they have enough people who are working there, it's a question always of, is this a training program for up and out? But most people, once they're there, they don't want to leave because it's, a very supportive environment. So I'm just going to look at a quick customized job example for everyone of a case, because here's how we took a neuropsych and put it into effect. So working with an adult in their 20s, loves video games and obscure movies. He also has Crohn's disease. And what kind of work is gonna work for him? He has very significant anxiety and very hard time leaving the house. So we start with volunteering. I'm a big fan, especially while the child is growing up. Academics are very important, and ultimately they're adults for longer than they are children. So we're really looking at skill development, internships, volunteer experiences. What is this person good at, and what can they do over and over? So here's an example of materials for the arts. That's something in New York City where you can sort art material for donation. And we took this client there, and he worked in the warehouse, and we look at what works and what doesn't. So what works? Self-paced tasks, light supervision, open space. But what didn't work was that the tasks were not fulfilling, getting back to that idea of purpose. And there was no social motivation. There were no coworkers for this adult. I think I went back. Okay. So then we tried something else. Let's find something that's going to be a little bit more exciting for them. And we used some of the skills that we knew we had in terms of sorting, but we changed the environment. The environment is just as important as what the task is. So he met with supervisors, got a little more comfortable. He started going every week on Tuesdays, start slow. Then all of a sudden he said, okay, I want to do a little more. So he's there on Thursdays and Fridays now. And for this opportunity, the supervisors are laid back. He has a better social environment there with his coworkers, and the tasks cycle through 3 main duties each week that he can do over and over. So that's how we take some of those recommendations in a neuropsych and apply them to a job, for example. We think about the same thing with housing. It's very helpful to take a look at an evaluation and then work with someone and then kind of put those 2 things together to understand what's the level of support the individual needs. They might not need 24/7 support. They might be able to live with a roommate and a live-in caregiver of some sort and some advanced technology that helps them be more independent. So we're really looking at how are we not always dependent upon humans to staff things? How can we enable the adult to be more independent themselves? And often pairing them with another neurodivergent adult can work. Sometimes one has strengths in one areas and one in the other. And, you know, for example, we have two adults, one who cannot read well and navigate the city on his own, and paired him with a friend who knows the train systems, knows the buses like the back of his hand, and they've become friends because one helps the other with transportation, and the guy who's not so good at reading is extremely social and friendly, and that really adds a nice element to this other female's life. So that goes back to that matchmaking piece. I want to talk a little bit about parent and family work, and then I'm going to wrap up. So we really, the parent piece is really integral here. The adult drives the process to the extent that they can. You know, how can they communicate? Not everyone can communicate verbally. We're, you know, really very open to trying to figure out what makes this adult happy, whether they are telling it to us or they're showing it with their behavior, or we have some type of communication that enables them to share that with us. And then when it comes to the parent and the family, and their goals are not necessarily aligned, as probably everyone on here has experienced, we really look at what is the parent's job description. And that's how we often back into figuring out priorities for our work. So, you know, mom, dad, parent, what are you doing on a daily, weekly, monthly basis to support this adult? And, you know, we've experienced this where I could say the exact same thing that mom says, and it's well received by the adult, and it's literally the exact language is just coming out of my mouth. At a certain point, they don't want to hear it from parents anymore, and truthfully, the parent doesn't want to have to do it anymore. So this is really about who else can be a part of the team, and who else can be guiding and supporting the adult instead of the parent. And the parent can be kind of in a parallel or separate type of role. And so we look at that job description and we try to take the pieces off where there's a lot of tension or where there's a lot of stress or struggle. And then a lot of the work we do is really around planning for now and planning for the future. What are the long-term goals, and how do we structure things so that families don't have to be involved in a, you know, a regular day-to-day experience. So, you know, that's where we take kind of that neuropsych, figure out what life might look like, practice, assess, try it out, make edits, and then try to figure out how we can create the scaffolding and structure that's needed to make the life more sustainable and to help families let go a little bit. I think that's going to be it for me, so I'll stop sharing. And thank you very much for listening. Amanda, you're up.
Sorry, I was muted. Thank you. Thank you both so much for presenting. I want to welcome people at this point in time to please generate any and all questions that you may or may not have in into the chat. I do see some starting to come in. This is okay. Do you know of any other companies in the MD area that help adult families in this same type of a capacity? You're now on mute, Allison.
I was just thinking out loud. I need to think about it, but I do. I mean, there's some, I guess, let me say it 2 or 3 ways. One is, this is pretty much a new field, thinking about case management for adults with intellectual and developmental disabilities. There's more out there for mental and behavioral health. There's kind of, if you think of older adults, it's a similar idea of the case management that they need. And then each state kind of has their own programs. You know, there's certainly, like, the ARC is a national model, and each state or city has their own ARC. There's some really great Best Buddies programs that are focused on employment or focus on even housing now. But I can take this person's information and get back specifically on what I know of in Maryland.
Perfect. And while you're at it, we have somebody asking about Minnesota and Virginia.
Okay, Minnesota has a lot of good stuff going on there because they have self-direction as well. Minnesota and Virginia, okay.
And now add Connecticut. Sorry, I want to make sure I get all the states. Um,
Connecticut has,
North
I guess,
Carolina too.
yeah, I can send out some information. Connecticut, it depends, they have some really good housing opportunities like Chapel Haven or Vista. There's also a company called ICOR, IKOR, which does case management for neurodiverse and older adults. And yes, I'll get back to you with more.
Okay. Somebody just made a comment that in Connecticut, it can be difficult because a lot of clients are refused for specialized services if IQ is above 70.
That gets very complicated very quickly because technically we can't speak to that. That constitutes legal advice in terms of what somebody would be eligible for based on their exact results. But the thing to keep in mind is it's not necessarily just about IQ. It's a combination of the IQ score and the adaptive functioning score. So 70 is a big number. And again, I don't want to make any judgments about that number exactly. But there are times in which people have higher IQs and far, far, far lower adaptive functioning skills. And I've seen anecdotally people qualify or be accepted with those profiles.
Mhm. Yeah, and there's more questions just coming into now in the chat about just not just states, but which insurances are currently covering autism assessment services. I can imagine, especially with insurance, it's not just which insurance companies, there's like hundreds and thousands of different plans within each insurance company. So I
Yeah,
don't.
it's complicated because I mean I tell people all the time, and we're not on any insurance panels, but we can provide an invoice suitable for submission to your insurance provider for out-of-network benefits. But if someone is contingent on insurance reimbursement, then the best thing you can possibly do is call your insurance carrier, ask about your specific plan and policy, and ask for a list of in-network providers, and then just kind of do due diligence of making those phone calls. There's times in which there's excellent options. Again, it depends on your specific policy, and that's why we can't make any generalizations about insurance carriers.
Great. There's a hand that has been raised. Kristen Brown. Can we give permissions for Kristen? Are you with us?
Oh, you know what? That was by accident. I'm sorry.
Oh, that's okay.
Forgive me.
Nice to hear from you. There's a question in the chat. Hold on, I have to scroll up to it because a lot have come in about, oh, here it is. Is there a comorbidity between ASD and BPD? Or how are some of the dysregulation symptoms teased out? This is a really good question.
It's a great question. I'll speak to the first part, and I'll let Allison speak to the teasing out the symptomology. But the reality is, unless there's an exclusion criteria in the DSM, ASD can be comorbid with any other diagnosis. And to speak to my comment earlier about comorbid personality disorders, a lot of people believe that personality disorders come from, an environment of uh, of exclusion or not being able to make the connections that you want, that are making you feel um, rejected by the community you're in. So as you can imagine, people who struggle with social emotional reciprocity, with social pragmatics, they can be ostracized, isolated, and that can be an opportunity for someone to feel like the world is a sad and stressful place, right? That the world might be cruel and unusual in some way, which can be a foundation to form something like BPD. And then all of a sudden you start to form, maladaptive coping or an inability to self-soothe, right? Which again is maybe exacerbated by the difficulties of the emotional regulation skills of people on the spectrum at times.
The invalidating environments, basically.
Yeah.
I guess when we're looking at a profile like that, we look at what seems to be primary, what seems to be the thing most getting in the way, and how do we create an environment that's going to be supportive around that, knowing that there's layers of different challenges there. But we have a lot of clients who have both of those, and really it's much more of helping the adult. I don't know if we mentioned this earlier, but the adults we've seen who are most successful in terms of self-esteem and a sense of belonging are those whose families have talked about their challenges and their strengths all along, and where they used certain language or they're comfortable with certain language so that they themselves can speak about their identity in terms of their strengths and challenges. And that's certainly looks at where we are in the timeline of disability, but the more the adult is able to advocate and they understand who they are, the better chance they're going to have of a more purposeful life.
Yeah. It is, I will say just anecdotally, it is a clinical presentation that we're seeing a lot more of with that comorbidity, which also, in terms of when we look at sort of like interventions like DBT and how DBT is presented and in what formats DBT is presented, I think it's important that the whole clinical picture is understood so that interventions that work with one, like especially when we're talking about things like DBT, are presented in a way that is digestible as well. There's a specific question for you, Dr. Rowe, around what is your opinion on using non-ADOS assessments such as I need to make my screen bigger, MIGDAS
MIGDAS,
for
yeah, no, it's
previously undiagnosed young adults.
absolutely. The MIGDAS I've used it innumerable times. It's an excellent tool. I mean, the reality situation is it's not a one size fits all for assessment. I gave an example of a cognitive test and a social emotional behavioral test and a adaptive functioning test, but you really want to tailor your battery to your client. There's people for whom the ADOS is not necessarily the best tool to evaluate and parse apart these symptoms. Sometimes you want to do the ADOS and something else. Again, we don't make any diagnosis based on singular tests, and we don't rule out a diagnosis based on a singular test. We want to make sure that we're getting convergent validity and making sure that we have the best chance for an accurate, valid, reliable diagnosis. Otherwise, again, there's too much opportunity for error, and we're trying our best to create a space in which we're getting as much good clinical data so that people can make informed clinical decisions. And that includes things like how does other mental health, affect the developmental issue and vice versa.
Any suggestions in working with college students who do not have family support due to cultural beliefs? I run into this frequently. I currently have a student who could benefit from testing and who wants testing, but the parents are not on board. They do not believe in neurodiversity, mental health, etc. The student is financially dependent on the parents in this particular case, but how do we work with parents who are not on board, basically?
Well, we have this a lot, and there are some real significant cultural implications here. And there are some really wonderful support groups out there, and even culturally oriented support groups, which we can look into. There are ways to get free assessments through different, like the ARC is one. If you go through your state DD system, they can refer you to an agency to get your evaluation, and there's usually some scholarships or state stipends to do that. It's kind of a parallel track. It's like, who can help the family over here understand the need for the validation, or the need to say, in a positive sense, my child's going to be more successful because they know what they're good at and what they can focus on, as they build their career. And the adult hopefully can find, someone in the DD system, a care manager or a social worker who can help hold their hand through that process. And if you want to reach out to me, I'm happy to find out what state you're in and see what kind of local resources we have.
Any comments on this, David, on your side?
It is a complicated situation because the reality situation is, and I see a lot of comments about this, there's just services aren't available. The states are overtaxed, the mental health system is overtaxed, and as insipid and high-minded as it sounds, there's 173 people in this room who are here to learn about neuropsych testing, to learn more about developmental diversity, to celebrate National Autism Acceptance Month. And I think that we try our best to get people the services necessary for them to be able to have more impact in terms of living life. But the best thing that we can all do as a community of mental health professionals and as humans is try to better understand what their experience is like, right? What the experience of someone who is neurodivergent, and help people feel comfortable and confident every day. So again, I know that these services are hard to come by and the wait list can be a decade long, and we do our best at United Assessment to provide, pro bono and sliding scale assessments. And, but again, the supply is kind of overshadowed by the demand in a lot of ways. But I think, again, on a very individual basis, the best thing we can do is try to understand and try to create a culture in which people feel more comfortable every day.
Yeah. There's some questions just coming in about how to contact our presenters. In a follow-up email, we will make sure that, slides are available to everybody, and we can also put in contact information as well, so that people have those resources. There's a question about United Assessment. Where are you located? Do you do kids around 5, 6?
So we do testing for everybody, everywhere, all the time, all ages, all diversities, all pathologies, from toddlers to geriatric cases, and we're located all over the country.
Great. Any other last minute questions before we start closing up here? There's just one more that came in about similar to the BPD comorbidity around a bipolar comorbidity as well.
Yeah, I mean, psychologists spent 100 years arguing nature versus nurture, and now we know that it's both. We believe in epigenetics. We know there's a gene times environment interaction. And as a result, as you can imagine, the kind of relational traumas that can result from being, again, diagnosed or undiagnosed with ASD from a young age and not being able to have your needs fulfilled can result in extra stress that might result in an expression of a bipolar illness that at some course in their life. So there's nothing excluding a BPD, a ASD diagnosis with a bipolar diagnosis.
Mhm. Anything to add, Allison, or?
Yeah, no, we have several clients with that profile as well. And that's really where I think working with a treatment team and
So-
knowing, who's on that team. And we have the good fortune of being the convener often, so we're the ones that are connecting, to the team and updating them, and even updating who needs to be on that team as different things evolve or people retire, however it works. So, trying to keep everyone connected is a big piece of the work we do that's very helpful, but making sure you have the right specialists and the right team really makes a difference.
Yeah, especially when there's that comorbidity, because I'm even thinking like specifically in this specific example that was given, or a question was asked around a bipolar diagnosis, where we know like that medication compliance is like of the utmost importance. And there's a lot of different reasons why people are non-compliant with medications. It could be because they just don't want to take the medications. They like the way that they feel when they're not on medication, or they don't like the way they feel when they are on medication, or they just forget because they have difficulties with executive function and creating systems and reminders, and really understanding the full clinical pictures and all of the nuances involved to create a treatment plan that addresses, the individual as a whole versus just, bits and pieces is really important.
We've seen time and time again young adults be diagnosed with autism for the first time, and they've been working with psychiatrists for a decade. And it wasn't until they started working with a psychiatric provider that specializes in young adults on the spectrum that they find real benefit to their psychopharmaceutical intervention, right? Because people who are neurodivergent means neurodivergent. You metabolize information differently. You can metabolize medication differently. Sometimes you can have contraindicated effects from the same medication that one would expect a different outcome. So it's really important that once you have this information, you use it, you leverage it to get, specific care, right? Individualized, tailored treatment.
All right. Thank you all so much for this presentation. As I mentioned at the very beginning, all of the participants will be getting a follow-up email where you'll be filling out a survey and then you get your CE credit. Also, if anybody wants to, reference this presentation after the fact, it will be up on a YouTube channel as well. Slides will be sent out and contact information will be sent out. So thank you all for attending. Thank you all for participating so actively in the chat. It was great to be here with everybody today. Thank you. Have a great afternoon.